This is Dr. Babak Azizzadeh. You are listening to the Smile Podcast, where I will be sharing with you my unique and holistic perspective on beauty, health, and wellness.
Hello.
Millions of people have surgery every year.
Or you could just get a boob job.
Using targeted Botox can be a miracle.
Smiling like that is a skill.
Your surgery has been successful. Hello, everybody, and welcome to the Smile Podcast. I'm Dr. Azizzadeh, and I'm really happy to have you here. And today I have a super special guest, one of my dearest friends, an amazing doctor, Dr. Tabib, who is one of the foremost experts in gastroenterology. And today we're going to talk about everything you wanted to know about coronavirus and your guts and your GI tract. And I think Dr. Tabib will be able to give us an unbelievable detailed information for you guys to have more knowledge, and knowledge is power. So I'm really glad to have you, Siamak. It's great to have you.
Thank you so much, Babak John. It's a pleasure to be here. Thanks for asking me to share this time with you and hopefully talk about some important stuff that's happening out there that really relates to everybody around the world, not just us here. But it's a pleasure to be here.
Well, Dr. Tabib and I have been friends for a long time. And actually, his wife and I went to high school together. And we've been friends, and we've been really close colleagues since we started our practice. Although we both went to UCLA and had some time together. But tell us a little bit just about your background and your journey of how you got here and why you got interested in gastroenterology and kind of how it's become your passion.
Sure. So just like a lot of other doctors, we've always loved to look forward in time and imagine ourselves as being physicians and helping people. And my path was kind of similar to yours. Started in UCLA as undergrad and later on in medical school there. And then I chose internal medicine because I wanted to learn as much as I could about medicine and physiology. And the more I learned about it, the more I became intrigued and interested about the gastrointestinal tract. And a very nice pathway from there, especially because I also wanted to be in the operating room and do procedures, was gastroenterology. So it was a combination of the best of both worlds, in my view, being able to do procedures and help patients immediately with an intervention that you can do, but also be able to treat chronic long-term illnesses as well, a lot of which have to do with the gastrointestinal tract. So it was the best of both worlds combined, and I believe I chose the right path because I like it more and more every day.
So during your training, you obviously dealt not only with, in your internal medicine training, with infectious disease and other issues. And in gastroenterology, one of the key areas is hepatology. And we know that hepatitis C and B and A, all three types of hepatitis, impact the liver tremendously. And one of the biggest breakthroughs in healthcare has been these antiviral medicines that have treated hepatitis. So before we get into coronavirus, I think you have kind of a unique perspective on that. Maybe you could kind of tell the journey of how hepatitis, which was one of the most difficult viruses to treat. And in fact, for us surgeons, one of the scariest things, because if you got a needle puncture or something like that, you were so worried about, it was a death sentence, essentially, for many people. How did that come about, and how do we end up kind of curing that?
Great question. So first of all, hepatitis, there's different types of viruses, hepatitis A, B, C, as you mentioned. It actually goes down the alphabet, D, E, etc. But the main one in question has always been hepatitis C, because number one, you don't get over it that easily. And if you become chronically infected with it, it can affect the liver, cause cirrhosis or failure of the liver. It can increase risk of liver cancer. And up to a certain point in time, it was the number one reason people would get liver transplants. There was really no cure to it. There were medications that suppressed the immune system, and we've all heard a lot about the immune system recently. But they would suppress the immune system and try to get rid of the virus maybe at best they were 50% effective, so it was a coin toss. And it wasn't a few weeks or a couple of months, it was about a year, sometimes longer. And the side effects were actually worse than the disease itself. But thankfully, over time, with a lot of research and a lot of money that went into research, over the last few years, much more effective treatments came around where it's just an oral pill you take once a day for anywhere between 8 to 12 weeks, and it's done. You're cured. The virus is gone. So it's an amazing breakthrough in the world of virology and infectious disease. And I honestly believe this can be done with a lot of viruses, and hopefully one day even with COVID-19 and the same type of SARS 1 and 2 type viruses, but it's going to take time, and it took decades for hepatitis C treatment to get to where it was today. Hopefully it's not going to take decades for current viruses to be treated better, and I think that definitely in the short interim, whether it's 6 months, a year, or longer, we're going to get to a better place with this current virus. But I believe that we have that ability, and hopefully, the big research entities and the big universities are continuing to work hard to get us somewhere.
Yeah, it feels like kind of the process that took 10 years is now kind of takes 1 year, because before just getting an institutional review board to start a research project would take months and months and months. And now it seems like from the government, the kind of the regulation, bureaucracy of it is really shrunken significantly. So hopefully we'll be able to kind of get a lot more clinical trials. And there have been, I think, a lot of clinical trials that have really impacted the coronavirus. So tell us a little bit about, everyone knows about the fevers and, breathing issues and the need for respirators. And one of the things I've done on this podcast is really bring in some of the other less talked about symptoms of coronavirus. And, like, for example, sense of loss of smell is a big one that people don't really talk about, but it's actually one of the most common symptoms. Tell us a little bit, kind of what are the general reactions in the gut with people who have coronavirus, maybe not at the level where they're like intubated, but just like maybe at the beginning of the disease and how it progresses.
Absolutely. So what's interesting is initially, end of 2019, beginning of 2020, as this virus was becoming more and more well-known and reported, a lot of the reporting and a lot of the focus on the symptoms was on the respiratory symptoms, the cough, the fevers and chills, but the ultimate progression to pneumonia and the sore throat. And it was interesting that at the beginning, there wasn't much discussion on any gastrointestinal symptoms. So for example, if you had some of these other respiratory symptoms, but you had also diarrhea, people initially, in the world of medicine, initially would say, oh, you have diarrhea, this is not COVID-19 or this is not coronavirus, because it wasn't as well known that it can also interact with the gastrointestinal system. As the months progressed into February, March, and later, and as more and more case reports started coming out of China and then later on in Europe, and ultimately here in the US, many universities started reporting the gastrointestinal manifestations of what they're seeing with patients that have turned positive for the virus. Even if it was a nasal swab that was positive, they were also reporting gastrointestinal symptoms. In fact, one of the chief complaints of patients that ultimately were going to the hospital in the emergency room wasn't necessarily I have difficulty breathing or I have cough. One of the listed complaints wasn't only I can't smell or I can't taste, but it was I have abdominal pain, I have fever, I have fatigue, and I have a change in my bowel movements, usually with diarrhea. And more reports have been coming out continuously out of Stanford, out of Columbia, out of Mass General, NYU, even locally in our own backyard at Cedars. Cedars and Michigan are doing some work together where anywhere from 30 to 50% of patients are actually presenting with gastrointestinal symptoms, with or without respiratory symptoms. So the gastrointestinal symptoms are actually starting to manifest itself. And when I look back in my own practice, end of 2019, every few weeks, few months, you would see a resurgence of what you think is a gastroenteritis, which means basically a stomach flu, whether it's nausea or vomiting or diarrhea. And a lot of these patients, we would do stool studies. Obviously, the stool studies did not include the COVID-19 virus in them. They still don't, believe it or not, to this day in the US, which is a big problem. But all these stool studies would be negative. So we'd say, okay, it's something that's maybe you ate something that was bad, or it doesn't look like, maybe it's a different type of an infection, but there's nothing to do about it. Just go home and rest. We wouldn't even know to tell these patients, okay, you may have something that's more infectious and you need to isolate yourself for 14 days. This was not the thought process, but a lot of patients that came through the offices, over and over again, were having these types of symptoms. In hindsight, a lot of these patients probably were COVID-19 patients. In fact, what's interesting is there was a protocol that was released from one of the hospitals in Wuhan sometime after the first quarter of this year, where they had noticed these gastrointestinal symptoms and started actually testing patients, not just their nasal swab when they were admitted to the hospital, but also their stool when they were admitted to the hospital. And they were noticing that a lot of patients who do have complaints of diarrhea, and in those series, there were about 20, 25, up to 30%, actually had stool tests that tested positive for the virus.
Oh, wow.
So now we start understanding, okay, this virus is not only in the respiratory tract, it is also found in the gastrointestinal tract. And in fact, that certain hospital in Wuhan would not release patients to go home until, number one, their nasal swab turned negative.
Oh, wow.
And number two, their stool test turned negative. So they wouldn't release them into the public without having a normal stool test without the virus. It took up to about 10 to 14 days in some patients after their nasal swab turned positive for their stool test to turn positive, which goes to show kind of the pathophysiology of this virus. Obviously, we're not hospitalizing everybody. A lot of patients are told to go home and isolate themselves or go in some sort of contamination control. But this can be very easily shed in stool. In fact, there are countries and in certain areas, even in the US, that are now testing sewage for population control parameters to see how much virus is out there and how much virus is being shed. And the next question is, well, why the gastrointestinal tract? Well, first of all, the gastrointestinal tract is the largest immune organ that we have. So if anything affects the immune system, guess where these immune cells are being made? They're being made in the GI tract or your guts, as the topic of this discussion is. So the guts are a big form of virus production. Immune cell production, and viruses can affect the gastrointestinal tract. So why does this virus affect the gastrointestinal tract? Without getting too much into the science behind it, this virus has a crown. That's why it's called the coronavirus. That's a series of viruses. And this outer protein layer or crown is what attaches to cells and is able to get the virus into the cell to wreak havoc. Now, the cells that are able to attach to the coronavirus crown have this antenna or receptor on their outside known as ACE2 receptor. And this ACE2 receptor is found in the lining of the breathing tube, lining of the throat, definitely the lungs. And that's why one of the areas that this is affected is the virus is able to get into the lining of the respiratory tract because of this ACE2 receptor that its outer protein can attach to and enter the cell. Well, guess where else exhibits the ACE2 receptor? Even more than the respiratory tract. The number one location for the ACE2 receptor is the gut, is the small and large intestine.
Oh, wow.
So that is why that there's a lot of gastrointestinal manifestations that can happen. Now, there's a lot of research being done. Is it a live virus that is affecting the gastrointestinal tract? How is it getting past the stomach acid? How is the stomach acid not getting rid of it? Could it be that if you're taking anti-acid medicine, then you can't get rid of the virus as well? Well, actually, it could be quite the opposite because
because there was a study, right, on
there's a study
Pepsid.
happening, I believe, in NYU, looking at very, very, very high doses of an anti-acid medicine called Pepsid that was initially observed to do better with patients that are on this medicine and also have coronavirus. Now, it doesn't mean that everybody should go out and take Pepsid, like, we were told initially, about some of the other medicines, but it's interesting. It goes to show we still don't know a lot about what's happening.
It's the unknown virus.
It is.
It's the known unknown virus.
But it does affect a lot of people in my field as well.
Wow. So now one of the interesting things is, we're in California, both of us, and the governor recently lifted restrictions on elective procedures.
Correct.
And in fact, one of the key procedures that he mentioned was that we want people to get back to doing their preventative colonoscopies,
yes,
and so forth. Can you kind of share with the listeners and the viewers how important that procedure is to the overall population health? Because a lot of the things that I worry about, and there have been articles, where are all the patients who've had heart attacks? Where are all the patients who've had strokes? Everyone's scared to go to the emergency room. Why are colonoscopies so important that could be even a bigger killer than potentially, if you don't do it, than the coronavirus can be? And why, and who's at risk, and who are the people that should be getting them?
Sure. A great question. And thank you for bringing this up, because really, more than anything else, it's really a public service message that we want to make sure that we can get across, whether it's during Corona times or COVID times or non-COVID times. Unfortunately, colon cancer remains the #2 killer of cancer in the United States. It equally affects men and women, and it affects people of all race and color. Now, it happens that certain races, such as African Americans, are a little bit higher risk because there's a little bit higher incidence. But in general, everybody can be affected with colon cancer. And it doesn't mean that, okay, if I didn't have it in my family, if someone's parents didn't have it or grandparents didn't have it, that they're not going to get it. Now, there could be a higher risk if there is a strong family history, but you do not need a family history to develop colon cancer. And the big part of colon cancer, and the reason we hear about colonoscopy or colon cancer prevention all the time, is we have to understand a little about how colon cancer starts. It does not start as in cancer. There are some cancers that start from a normal cell to a cancer cell. This is not the case here. Colon cancer actually starts as a simple small growth that we refer to as a polyp, kind of like a pimple that can happen on the skin. This turns out to be a pimple that can start somewhere in the lining of the large intestine, what we call the colon. And it could take years for this to happen. It doesn't happen necessarily overnight. But as this polyp, or as this growth, which is a benign tissue, it's a benign growth, there's no cancer cells in there. But as it grows, if it has the potential to one day turn into cancer, then it can turn into cancer. And the problem is there's no symptoms when you have these polyps. People say, well, I don't have any symptoms, I don't have any pain, I don't have any bleeding, I don't have any weight loss, I don't have any changes in my bowel movement. I'll go get a test if I have these symptoms. And that's the problem, because once you develop these symptoms, obviously these symptoms could be related to a lot of different things. So it doesn't mean if you have pain or changes in your bowel movements or even weight loss that it means you have colon cancer. But these are things we need to look into. But these polyps really are not symptomatic, so we can't really assess it based on symptoms. And unfortunately, we can't just look at somebody like we can look at their skin and say, you have a mole that we need to remove. It's not that easy. We have to use a camera to look inside under sedation to find out if a polyp is there. Well, the good news is that if a polyp is found and is removed, And if it turns out to be a precancerous polyps, and there's a very good chance that polyps can be precancerous, anywhere from 20 to 50% of the time that they're found, they can be precancerous. Then by removing these polyps, we prevent that one single polyp from one day turning into cancer. And it could be that somebody has no polyps when we look, and that's great. Could be they have 1, 2, sometimes we find 20, 25, 30 polyps, depending on, you know, the physiology of that person. But by doing the colonoscopy procedure, which is about 20-minute, 30-minute procedure under sedation, there's no discomfort because patient's really asleep and they wake up and it's like having a dream and you wake up. But by doing this, by removing these polyps, we can actually prevent colon cancer. And that's why it's recommended for everybody, whether they're male or female, no matter what their skin type or skin color or race is, to start. It used to be at the age of 50, and then it was recently changed for all individuals, not just African Americans, now down to the age of 45. Now, there are certain circumstances if patients have a family history, or if they're exhibiting any symptoms that could be related, they may even have it at a younger age than 45. But by the age of 45, maximum 50, everybody should have this test. And, you know, I know that over the last few months, things have been on hold somewhat, but this is one thing that cannot stay on hold. Yes, 1 month, 2 months, 3 months, maybe, but you cannot put this off for months and months at a time or even longer, because not only can we prevent colon cancer, even if a colon cancer is found, when we do a colonoscopy, as long as it's in its early stages, and in medicine, you know, in the world of cancer, we call stage 1, 2, 3, and 4. If it's found in the early stages, such as stage 1, it can be over 90% of the time cured. It may require surgery, but it can be cured 90% of the time without even having any other treatments. And that's what we want to prevent. We want to prevent colon cancer, and for the ones that slip through the cracks, we want to find it early, get rid of it, cure it, because as with all other cancers, it can potentially be very debilitating and obviously life-threatening.
So the message is find a safe doctor who understands COVID situation, a safe ambulatory surgery center that this can be done, and they have protocols, and don't delay it too long because it's a population health problem. Now, interestingly enough, Dr. Tabib actually has done my colonoscopy, and
I wasn't going to mention that.
I will tell you a really funny story that, you know, I'm a little bit of a high maintenance doctor, right? So, so I called him up and I said, look, I have 1 hour, and Dr. Larian, who everyone knows, and I kind of do a lot of things together. We want our colonoscopies, and he was kind enough on his day off in the morning. He did my colonoscopy at 7 o'clock. Dr. Larian's at 8. And then at around 9 o'clock, he took us to Nate and Al's, and we had the best breakfast, steak and eggs, that we could have. Unfortunately, Nate and Al's is closing, but that's our anecdotal story of the day. That was just amazing. But yeah, so that's a very, very important message that shouldn't be taken lightly. And, you know, especially over the age of 45, I think everyone should, you know, when it's all safe in your area with the right doctor and so forth, this is something that we want to do. Now, before we finish, we've covered so many things, but before we finish, I would love to, we have you here and you're so smart, so I want to kind of pick your brain. What are some of the things, you know, we always talk about GI health, right? Your gut is a ginormous organ, essentially from your mouth all the way to your colon. And what are some of the foods and dietary habits that could be great not only for our guts, but also can help us prevent diseases and other things that you know, can be taken lightly?
Sure. So first of all, our guts are made to help themselves out, as long as what we're feeding it is appropriate. So imagine your system is like a car, okay? You're gonna put gasoline in it. You don't necessarily need to put the highest grade of gasoline, but you need to change the oil every once in a while. You need to put gas in it every once in a while. You need to take it to be serviced once in a while. And you can use it, but not abuse it. And the same thing with our body, and especially our gastrointestinal tract. So there is no one specific food type over another that is going to help us more than the other one. And everybody's different. You know, with all the allergies available out there and with all the food intolerances and whatnot, you know, it's not an easy question to answer. However, in general, what we talk about is you need to consume a low-fat diet, not a high-fat diet. A lot of people believe in the Mediterranean diet, which I believe is very important. But it's also important not just what you eat, right? And junk food and outside food, which some people have continued to eat a lot of outside food during the last few months, and some people have actually started to eat more homemade food. And in fact, you know, I've had more patients who have, or I've had patients who have had less gastrointestinal symptoms because they've been cooking at home recently and not going out as much to eat. Some people have actually lost some weight because of that, and they wonder why, and part of it is because they're not eating outside food. I'm not saying outside food is bad, and some people don't have the ability to make food inside the home. But we have to make sure that we're eating a healthy, well-balanced diet. But also, it's how we eat. You know, some people's intestinal tract requires them to eat small portions of food more often. Every 2 or 3 hours, they need to eat something small because that factory with their guts needs to digest the food easier. Some people can wait longer in between eating meals, especially skipping their morning meals, which is now kind of a popular diet called intermittent fasting. Well, that may work for some people, but if you have some gastrointestinal issues, that may actually work against you. So you have to pretty much learn what works best for you. You have to figure out what are the foods that you can't tolerate. But in general, eating a healthy diet, which means low fat, not a lot of carbs, not a lot of sugar, and ultimately combined with exercise is going to be key, because stress and anxiety have a huge impact on the gastrointestinal tract. It is basically our second brain. It's not just our biggest immune organ, it's also the second brain. And there's interventions from our spinal cord to our intestinal tract and to our guts that are very complex, and we probably at best understand 1% of what's going on.
Wow. I know. I feel it. I mean, you know, when there's anxiety, lack of sleep, stress, it's all in my, you know, it shows up in my stomach. I mean, you feel it.
Yeah.
I want to thank you, Sia. Honestly, this was awesome. I think one of the goals of this podcast, you know, it's for beauty, the beauty of guts.
Yes.
But more on the health and wellness, obviously. And what I wanted to do was kind of get really deep into a topic, and because most of the news that we hear is a 1 minute like summary, and when you get interviewed, I know you get interviewed often, they're always like trying to get a snippet, you know, and I wanted to like really get, you know, detailed information about a few things that are, I think, very pertinent right now and important, and you've done that, and I really, really appreciate it. And I hope once the situation is all over, we have you in a studio and we can talk about a lot of different topics and more in depth. And I really appreciate your time.
No, absolutely. Looking forward to it. Thank you again for having me on your program, Bob. This is amazing. What you've done here, really just from an educational model to people, is very well timed and needed, and I think you're doing a lot of good out there. So please keep it up, and I'd love to do future interviews together. It'll give more material for my 9-year-old to Google. He always Googles videos about us, and there's some interviews we've done together. And
yeah, that's right. We've been on panels and so forth.
15 years ago.
Oh my God. And Dr. Tabib can be found. He practices at Cedars-Sinai and Lapeer Health Systems and in Los Angeles, and he's amazing, and I really, really appreciate it. And for our listeners and viewers, please leave comments for us, suggestions, rate us, and let your friends know if they have any interest in learning more about beauty, health, and wellness. And I appreciate all your time. Okay.
Thank you. Stay safe.
Have a great rest of your day.
Thank you. You as well. Bye-bye.